Hello there and happy Friday night. It's Friday night. We're having Dystonia happy hour here based on your questions. So thank you for your great questions. If we haven't met, my name is Julie Hirschberg. I am a neurologic physical therapist and I am the owner, founder of Re+active Therapy and Wellness. I'm in the Los Angeles area and I also do a lot of teaching and mentoring with clinicians. That's through Re+active education. And I get a lot of great questions from clinicians, from patients all of the time. So I love to just hop on here and answer your questions, which, by the way, I'm just going to kind of scroll through here. Feel free to put in the comments or submit a question and I'll try to get to it tonight. So the topic has been dystonia this week. And if you're not familiar with dystonia, dystonia is a movement disorder, neurologic disorder that involves involuntary muscular contraction that usually takes a joint into a bit of a twisting motion. And it can occur for several reasons. A lot of times just idiopathic out of nowhere. It can be genetic, and we do see a lot of people where it's task specific, meaning it's in runners, and it's a runner's dystonia, or it's in walking or typing or in musicians. And we've been sharing about dystonia this week a lot because we have been working with a lot of folks with dystonia. We do a program at Re+active, an intensive program where people spend 1 week, 2 weeks, 4 weeks, 16 weeks sometimes with us, but often it's about 4 weeks, and we work together intensively, physical therapy, occupational therapy, psychology, working with that person 8 or 10 visits per week. So it's intense. And I had folks ask, like, what are you doing? First, like, what was the frequency, which is usually 8 to 10 visits per week. If they're doing something over the course of 4 weeks, it might be more visits per week if it's just 1 week. And I shared a little bit today and in other posts throughout the week about the kinds of things that we do for dystonia. And sometimes when you just see like the pre or post video, it kind of looks like, wow, that's pretty magical. That person just like, poof, got better. But not without a lot of work, because we know in dystonia that there have been brain changes, particularly in some of the sensory and motor networks and connections that are driving the dystonia, particularly with the task-specific dystonia. And it takes a lot of practice to make brain changes. That's one of the principles of neuroplasticity. And when we go to design a program for a person with dystonia, we're looking for a lot of repetition of practice. And so I shared today some of those keys behind the practice that we do. So I shared 3 things, one of them being nervous system regulation. So one of the other pieces, the important pieces of the neuroscience of dystonia that we know is that it can occur due to a disinhibition in the central nervous system. And what we want to bring to any person's nervous system that is overly excited and lacking inhibition is bringing nervous system regulation. This may mean that the person needs autonomic nervous system regulation, maybe more parasympathetic activity to help inhibit some of that excessive movement. So it's really helpful to start with nervous system regulation if that's not already something the person is doing. And this can look so many different ways. And I like to look actually and see if a particular technique or practice changes that person's dystonia. So for example, if I just look at a particular type of breathing, like an extended exhale, and the person has cervical dystonia, I can very easily look to see if that changes their head position. And then we incorporate that into treatment. But breath is kind of the most simple aspect, and sometimes it can totally not work. It doesn't mean that that person doesn't need nervous system regulation. They may need something else. They may actually need movement. They may need rocking motions. We love using a rocking chair, for example. They may need deep pressure or grounding type activities or heavy work type activities to drive some of the sensory changes, which is actually onto the second tip, and a big piece of what we do in our programs is sensory training. So we will look for sensory tricks that are part of actually the diagnostic criteria in a dystonia. And I knew this was going to happen. It's my dogs. I always will go into a live and my dogs are sitting here with me and I'm like, oh, they'll be totally fine. And they never are. There's a squirrel, there is a movement outside and they need to be moved. And I don't know why I always think they could just hang out with me here. I love my dogs. So the sensory tricks. So there's many different ways we explore this, but one of the ways that you could really look at is how can you change the sensory information coming in from the body? And that can be in positioning and posture. So I love to take people upside down or inverted or running in different mechanics or on different terrains, for example. All of those things are great ways to pursue the sensory changes that we're looking for in dystonia treatment. The third tip that I shared today in a little video is to look at the pieces that might have contributed to the development of the dystonia in the first place. And these are the underlying factors. These are things like joint mobility and strength. These are things like kinesthetic awareness and proprioception. Joint stability. So for example, we might see people with hypermobility that then overused a particular movement or joint through a repetitive practice and develop dystonia because they an underlying factor may be that they lacked joint stability and proprioception. So we want to help that and restore that. So treating those underlying pieces. So those are literally, if you don't know where to start, starting with those three. Really, really big. I'm just going to look again and check again. If you have questions, certainly you could put them in the comments here. And just thanks so much for joining me live. The second question that I got, so the first question was kind of about our programs. What do we do? I talked about the frequency and some of the pieces that we bring, which, by the way, this is not just physical therapy. So it's physical therapy, occupational therapy, psychology, yoga therapy, all working together on these pieces. Nervous system regulation, sensory and motor training, addressing the underlying factors. Another question that I got was about Botox, and it was such a great question. And this question comes up a lot in dystonia because if you look at the literature and if you talk to a physician, Botox injections and sometimes medication are kind of the mainstay of treatment, and they're the most highly researched forms of treatment in dystonia. And Botox can be very effective, particularly for cervical dystonia. The research supports this, and frankly, this is what I see in my practice. When I work with a person with cervical dystonia, I'm usually working right alongside a movement disorder neurologist who is highly specialized and trained in dystonia, and they're doing Botox, and we're working side by side to figure out what muscle combinations are the best, where can we tweak and change dosage. I'm not tweaking and changing. I'm not giving the injections, but this is a conversation that we're having. And I've had really great success. In fact, I have one person right now that literally the dystonia symptoms from her cervical dystonia are gone. She's still getting Botox and she got great therapy. And now we're looking at, can she actually wean off of the Botox and still have really good control? So I'll keep you posted on her. But the literature does show that it can be very effective in cervical dystonia, and it can be very effective combined with therapy. And typically what we'll do is we'll look to schedule therapy 2 to 3 weeks after injection so we can assess, see where they are. That's when the Botox should be starting to have some effect. And then we'll work with a person over the course of the treatment of Botox so we can look at the change over time, see when it might be wearing off, see what the effective, and train at those different time points. I think that's really, really important. And again, we've seen really great results with therapy, with an integrated program right alongside Botox. But this person actually asked me about Botox in the lower extremity for, actually this person asked me in functional neurologic disorder. So we'll get to that too. But I want to talk about it for task-specific dystonias. This has not shown to be as effective in the literature. And I think honestly, a part of that is that the population of folks with task-specific dystonia is very heterogeneous. There's a lot of variety. It's musician dystonia, it's writer's cramp, it's runner's dystonia, it's with walking, it's with other tasks. And so everybody's very different. So the studies are very small. So I'm going to give you my clinical experience with dystonia and Botox. And my clinical experience is that in a task or focal, task-specific or focal dystonia, I've not seen that the Botox is as effective as it is in cervical dystonia. And in fact, I've seen people get really weakened by the Botox, because that's what it does. It weakens the muscle. And it does it temporarily, right? So there are not a lot of risks. There are certainly risks for Botox, but not a lot of risks for doing a trial of it. The weakening and more, what I would say more permanent weakening occurs over long, prolonged use of time. And so I just have not seen it beneficial in a task-specific dystonia. I've seen people get weak. And for example, in a person with it in walking or in running, it's really problematic if your posterior tibialis gets weak. That's an important stabilizer in your foot and ankle. And so you don't necessarily want to weaken that over the long term. And so what I would say for the folks with runners or walking dystonia who are, maybe looking at Botox is I would encourage neuro rehab. I definitely would, and see if you can make some of the sensory motor changes that are underlying the dystonia have an impact for movement for you. Now, I'm going to say that, and I actually do have a client who has a task-specific dystonia that moved to many tasks, and this is not inevitable for everybody, but you can see something that started in walking, moved to running, move to cycling, move to other tasks. That can happen. I do have a client that did pretty well with Botox for about a year or so, meaning she regained some control with that. But then unfortunately had the weakening side effect of it over time. Did do better with some of the sensory and motor training. Actually, I've never gotten to work with this person in a more intensive manner. And now that this is the primary way that we work in Re+active, we work as an integrated team, we work in these intensive bouts, I've definitely seen much more improvement than I have seen over longer periods of time where it might be just me working with a person. And that's because I think I'm missing a piece of the puzzle that our OT, psychology, yoga therapy team can get to. Now getting back to this question about Botox, I have not recommended Botox for a person that has abnormal movement that is not related to a repetitively active singular muscle. So that's one of the things in dystonia and idiopathic dystonia is that you can typically, and in fact, a very good movement disorder neurologist is actually going to use EMG directed or ultrasound directed botox to get specific to a muscle. Sometimes it's just one muscle that is clearly the driver of the movement. And in other forms of involuntary movement, so chorea, myoclonus, tremor, functional dystonia, that is not the issue. The one muscle activity that is invariable is actually not part of the diagnosis. And so that use of Botox in that case would not be indicated. And so I haven't recommended that for a person with a functional neurologic disorder. And of course, Botox is used for a lot of other things. So people might use it for contracture, right? So Botox in a combination with serial casting, if a person has a contracture in a joint, I've definitely been a part of that, definitely been helpful for people that might have contracture and increased tone. But again, in a functional neurologic disorder, that's not the case. So really, really great questions sent to me from clinicians this week that I so appreciate. So keep the questions coming. I love hearing from you all. And let me just look here again. I don't see that I missed. Sometimes it's hard to see if I missed a question in here, but I don't see any. So I just want to thank you for joining me on a Friday night for a little dystonia happy hour. I really love these topics. I love the topics of neurologic disorders that are not as well understood, maybe kind of confusing, things that we didn't learn in school as physical therapists. And I appreciate your love, your interest, your curiosity in these pieces as well. So I want to just thank you for being here. And I love this question that is totally not related to dystonia, but you're here and hey, I'm here for it anyway. Random question is for the people in the comments. So if you've got comments for this person here, worried about getting into PT school. You're in high school, I think. You have a C in AP 2 and Gen Chem, or maybe you're in college, rising senior next year. Any suggestions? No, I think you're in college. I'm sorry. And reassurance, 500 plus years of experience. Well, that is amazing. And I will tell people, we work with a lot of people pre-physical therapy, pre-occupational therapy. They're volunteering in our clinics. They're doing great things. Yes, thank you. Kirk, maybe, a junior in college. I saw AP and I thought like an AP class in high school, so I apologize for that. I realized with your experience that you are in college. And what I want to tell you is to not give up. I think if you keep going, one C, 2 C's, not going to be the end of it for you, for sure. I've also worked with lots of other folks who maybe had to retake things again to get them the second time. Maybe you didn't have a great teacher the first time, not your fault. So I'm going to tell you to keep going. It sounds like, in fact, if you're here, you're pretty motivated and you really want to do this and you want to make a difference in people's lives. And I think that means the world to getting into PT school. So I'm not an admissions director at out of PT school. I am on faculty at USC. But I don't make the admissions decisions. But I work with a lot of folks, a lot of our volunteers or staff at Re+active that have worked really hard to get into PT school and maybe don't get in the first time and maybe not the second time, but they keep going and they make it and they do really, really well. And honestly, I think it's the best career in the world. I absolutely love being a physical therapist. I love being a neuro PT. I love working with other clinicians in my life. I honestly can't think of anything better in the world. So I'm going to tell you to keep going and keep doing it. And your grades happening right now are not going to be your end all be all for the future. So thanks for the random question. There might be others to share their words of advice. And you are so welcome. Thanks for showing up. Thanks for being curious. And I'll be rooting for you. I'll be rooting for you getting into PT school. So thanks so much for being here. I'm going to sign off for this Friday night. And keep the questions coming. Send me a direct message if you have questions. I love your all questions, and I love chatting with you every week. So thanks so much, and we will catch you next week.